Thanks so much for having me. Donil and Dr. Johnson, thank you so much for inviting me and having me here. I'm at the University of Washington, Christoph Hofstetter, I'm a spine surgeon there. And what I wanted to present to you today is using a fully navigated system that Joymax came out with and that we're going to soon implement at the university that takes, the radiation exposure to both the patient away and the surgeon and the staff. And so I'm very excited to show this here. And basically, I'm going to demonstrate a transforaminal approach. We do L4-5, and I'll show you the steps. Again, typically for a procedure like that, so we call it the TELF procedure, so transforaminal endoscopic lumbar foraminotomy, between 1 and 10 minutes of fluoro time, again, depending on who does the surgery. But it's a significant exposure also, as you can imagine, you have to wear lead. So I'll take you through all the steps of this really exciting new technology from Joymax here right now. So we already attached a tracker, so like with any other navigation device. So we use navigation for our instrumented cases at the university. Same here, you have a tracking system. This is not an optical system. It's a field, electromagnetic field type of system. So here's the field generator, and then here's a tracker. And so let's bring in the C-arm, and then we have some tracking devices. Levon, would you mind rotating that in there? So we'll get an X-ray. We'll register the patient quickly. And so you see you have an AP and a lateral tracker. And again, this whole thing is, I'll step back because I don't have lead on, as we discussed, so we'll get a quick shot there. All right, 6 feet away from all the viruses and radiation sources. Here we go. Perfect. All right, X-ray. Great. Get a shot quickly. So now we get the AP shot, and again, we do the X-ray here to register the patient, so X-ray looks perfect, so you can come out. We can now transfer the data, and we'll do that in the background here right now. We'll take out the tracker devices, and let's see if everything worked out here. So we have a needle. The amazing thing, the reason why the electromagnetic navigation was chosen for this is, as you can imagine, using such small approaches with an optical navigation system that would be attached to the handle of the instrument, you could not navigate the tip of the needle, which is bending. And so the accuracy that you want to have with a system like that would not be given with another technology. So we'll have this here. We'll go to the screen here right now. And we'll register so that the system knows what tool I'm using. Marking pen, please.
Hey, Christoph, that tracker that was taken off, is that done sterilely?
Yes, that's sterilely. So you have the plates are sterile, and then you have like a little sort of drape on top of that. So that comes out of the field, and then everything is sterile at this point. The box is also wrapped in a little sterile bag. So yeah. All right, so now I can mark the disc space. We do 4-5 there. So I mark the disc line, mark the approach angle. Again, I'm going to go roughly, the tip of the SAP is there, mid portion there of the Camden's triangle, so roughly that. And then we typically do a lateral mark that you can pass ventral to the SAP. So approach angle would be something like this. And then we can mark the incision here. Do you have a knife, please?
So you're going right L4-5, correct?
Yeah, right 4-5. And so we mark the 2 lines. Again, the way I like to do this, and again, it's all in the AO courses and the book that we wrote recently. So the disc line, inclination, a lateral line, and then as you can see here, I'm just bevel is ventral with the needle, and then we advance to the foramen. You can see that on the screen. Is the screen visible there? Yeah, perfect. Okay, so you see that. Maybe you can remove
the AP's is being blocked by your video, actually.
So now you have to decide. Do you like me better or the AP? Okay,
there you go. Right.
Oh, great. Okay, I lose. All right, so a little bit here. Nostril. So advancing the needle here. Again, I'm passing the facet joint here right now. I'm actually feeling the facet joint, so I have to lift my needle. In fact, a little trick is to rotate your needle there so we can pass ventrally there. There we go.
So could you do this on an oblique view if you wanted as well?
You mean a pedicle view from the side?
Yep. Mm-hmm. like
Yeah, yes,
yes,
like you do a discogram. Yes,
yes.
actually, in fact, that's how I started. But it is quite challenging to explain that to arbitrary X-ray tech. So that's why
Yep.
we do everything with AP and lateral. It's just easier. So now we've placed the tip of the needle into the Camden's triangle. We put a little K-wire in there, and again, you see all of this is done without a single shot of X-ray. So my back doesn't have to wear lead, which is awesome. Okay, so then you have a then you have a dilator that is coming in there right now. I don't know if you see that in the camera. So this is dilator. The dilator, again, quickly registered. Again, it takes 2 seconds to do that. As you can notice, really the system has come a long way since I used it in Germany a couple of years ago. They have really done a lot of work. So you see that I put the dilator right in there, right on top of the pedicle there, good position there. Keep the K-wire in place, take out the registration. Again, at this point, typically for this, you need an AP and lateral X-ray. But again, you save all this. This is something called reamer, bone reamer, and this is really the distinguishing step of modern transforaminal endoscopic technique is these crown reamers. And if you can see, in the history of transforaminal approaches, we all know the inside-out techniques that Tony Young pioneered really. And then Hoagland came in and sort of added this foraminoplasty to this. And then we, last year, published a paper on a trans-SAP technique where we don't even go into the foramen blindly anymore. And that's all made possible with these reamers because you don't have that entering the foramen blindly anymore, which reduces the rate of postoperative paresthesias that you can see. Levon, would you mind just helping me with the push-up, please? So now we go in there, counterclockwise, doing the approach here. Here we go. Would you mind just putting a push on? Okay, so we go in there. You can see that even the round has little teeth on there. It's very cute. And you go in there, and now again, as you have heard before, I can't emphasize that enough. Being a main teaching university, there's nothing more important than having seen this open first. We see it again and again where trainees that don't see open surgery, freehand pedicle screws. I'm going to reaming here right now, as you can see here, right into the foramen. So now I'm just through there. You can see that I'm right at the SAP there, reaming this out nicely underneath the exiting nerve root. And again, you just have to have seen that before. So I can't agree more with the talks, excellent talks that we had before, that open and MIS is a must to master before you seriously consider doing these type of surgeries. All right, so we go here again. The next dilator, one size up. Go.
And Christoph, how close does that box have to be to your surgical field?
Typically, it's a little bit lower. The issue here that we have in the lab, it's like these metal tables, and so, did I come out? I think I came out a little bit. And so we can probably just go back and mess with this. Typically, it's a little bit farther away, but we have some interference from the tables, so we had to go a little closer. Okay, we get the cable out there. Here we go. All right, so next dilator's there. There we go. Actually, I can leave it in there. All right, so the next dilator's in there, and the last reamer. Again, the reamers do the foraminoplasty. The foraminoplasty is done really to keep you away from the exiting nerve root. And again, it's something that Dr. Hoagland pioneered. Would you mind helping me again with the pusher? And that makes the whole technique not only safer, but it also, as you can see in a second here, it also allows you to appreciate the anatomy. And being at a training institution and teaching institution, I really want to see the traversing nerve root first before I grab anything. So it's you always try to visualize the neural elements first before you address the pathologies. You can see there here, I'm reaming there the SAP, and I'm getting more and more in a very favorable position here. Crown reamers, clockwise, reaming counterclockwise to the muscles. The clockwise and counterclockwise is really an art that people forget because people don't have watches anymore, but yeah, soon we have to learn it in school. All right.
Do you think that a foraminoplasty qualifies as a foraminotomy?
So the difference is, so foraminoplasty is really, it's something that I never really liked the word for that, but I think there's a role for having that foraminoplasty name. What it really means is you're removing bone and creating space, but you're not directly decompressing the nerve root. So in other words, it really removes part of the SAP and gives you space so that you don't injure the exiting nerve root, but it doesn't decompress the exiting nerve root, because in order to decompress the exiting nerve root, you also have to remove yellow ligament, bone spurs, and other stuff. So it's part of the foraminotomy, and it's kind of, yeah, a little bit of an interesting nomenclature, but I came to accept it. Because it makes sense. I mean, it's like, as you see, when you do a lot of these, a foraminoplasty is not the same as a foraminotomy. A foraminotomy is really seeing the nerve root. I'll take the Vapoflex, please. So the Vapoflex is a bipolar, so now you can see the view here right now. I'll be pointing it out in a second. A little bit of, obviously, there's a little soft tissue here that we're going to get rid of.
So we're not seeing the endoscopic view yet.
Oh, can we get the endoscopic view up? As interesting as my hands are. So here, the camera view. There we go. Can we get the endoscopic view up? It's not up yet. Here we go.
There we go.
Here it is. Okay. So here, a couple of things here right now. So let me just clean it out. There's obviously some soft tissue in this thing. Pituitary, please. Pituitary. There we go. There we go. So it's removing that a little bit here, cleaning it out. Okay, and so now that's kind of the first view I like to see. I think we have a little bit of yellow stuff. Would you mind just cleaning the scope there, please? Thank you. Going in there. And so that's the first view. Vapoflex, if you train here at the university, then typically the first view that I let people see is, that reamed bone. That you see that reamed bone here? So that's what the Troimax reamers, the crown reamers did. So they reamed out that SAP, and here's the jury shot, right? So Dr. Hofstetter, you're doing transforaminal fantasy surgery, right? Give me a Harrison. Then I say, well, isn't that the pedicle that we put on yesterday, T10 to pelvis? We put the pedicles right in there. So I'm putting this is my jury shot. You put the kerrison around the pedicle there. And why is it so important? Well, because once you have the pedicle identified, then you can identify the traversing nerve root. You visualize the traversing nerve root, and you can typically take out a disc or decompress the lateral recess. So right now we're looking, Vapoflex, please. Let me get this in focus.
Yeah, could you orient us with respect to what's left, right, and then ventral and dorsal?
Absolutely, absolutely. Thank you. So this is caudal. I'm on top of the pedicle here. This is a medial aspect of the pedicle here. So it's caudal pedicle. SAP comes up there. SAP, 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 all the way up there. This is the end of the SAP is up here, the tip of the SAP. So Jeff, you asked me before what the difference is between a foraminoplasty. Foraminoplasty, we've kind of scarred it, trimmed it down a little bit. For a foraminotomy, depending on the anatomy, I would probably resect more of that SAP. And then we have all this stuff up there that contributes to our failed spine surgeries, right? Because there's a ton of yellow ligament, and there's a little bit of disc stuff in there. And underneath ventral to this yellow ligament is exiting nerve root, right? And you wouldn't believe how much pathology we find in there that is just, often not addressed with our traditional surgeries. And so we do this here right now. So now we've cleaned out that area, just a smidge pituitary, please. And the next step is obviously, now we have identified the bony landmark again. And then we want to see the traversing nerve root, right, before we sort of do some damage in there. Harrison, please. So here's, again, left side is caudal. At 12 o'clock, it's dorsal. 6 o'clock is ventral. Here's the disc annulus. And then here's the medial aspect of the SAP there. I'm going to hook my little kerrison in there and go north here right now. Patient is still bleeding, even though I don't think there's anything attached to this. Okay, so we'll take some little bites, right? And I'm just taking those bites along the yellow ligament, right? This is all normal anatomy. Here's, you see the yellow ligament there? So this is just the same move we would do in the lamina, just coming from a little bit more lateral. Go, couple bites, vapoflex please. And then once we open this up a little bit, again, a little sloppy with the working, then we'll see the traversing nerve root here in a second. So here, pedicle, so that's the L5 pedicle, SAP. You can see this wonderful transition here right now between the SAP and the attachment of the yellow ligament there. Which is, the anatomy is quite spectacular here. It's a little bit more schmutz here. Pituitary?
Do you have to do the foraminoplasty step? Is that a requirement?
It keeps you safe. I mean, you know, I think in a young person that you just do a discectomy and has a big foramen, you don't have to. Typically, we don't, again, as you can see here, the facet joint, we don't even see the joint. We're just thinning out the SAP. So we haven't seen any mechanical issues with that. So there's no downside except for you take some time. Vapoflex? I think it's just, in our hands, it has really sort of gotten rid of the nerve root irritations that you sometimes see with a purely transforaminal technique. That's why we typically now do the trans-SAP technique, where basically your working corridor is the bony substance of the SAP. And so back there, we start to see the nerve root. Just have to get this off a little bit more tissue here. Pituitary. And again,
so are you doing the trans-SAP approach now, or is this the standard?
You know, we removed, because we did a standard approach with removal with a foraminoplasty. So because they don't have a navigated GMC needle yet, it's in the works. I think it will be available. I don't know when is it going. Do you know when it's going to be available? In a month or two. So, and who wants to wait that long? I don't have time.
And where would the Jamshidi needle go on a trans-SAP approach?
It just docks right on the lateral aspect of the SAP, and then you just basically hand it in there. Vapoflex. And so the nice thing is you never have anybody poking around the foramen, which is again good for the patient. Here we go. And then here we have the yellow ligament back there, and then open up the epidural space. And we should be able to see the nerve root here in a second. I think it's already, we saw it already a little bit.
For paracentral disc herniation, that's a little bit more central than lateral. Would you go for a standard interlaminar approach or a transforaminal?
You know, the endoscopy folks always make a little fun of me because I came from the MIS field. So I like the interlaminar approach for a lot of approaches because it's a little bit more, you know, it allows you to also do some decompression surgeries. Here with this one, you can do a ipsilateral lateral recess decompression. It's just a little bit different. The reach is different, so you can go more medial. And so now we're starting to see the neural elements here immediately. I'll show it to you in a second. So here's the annulus and the posterior longital ligament here that I see here. Again, this is dorsal, caudal, ventral is here, yellow ligament there, and then back there's the dura is right. I think we're looking right underneath there. It's right behind there. You see that behind there? This is the nerve root right behind there. The drill, it's actually pulsating down there. That's the prominent cadaver. You see it back there behind the, pulsating behind the ligament. There's, do you have a pointer or something? Or do me the carousel one more time. Yeah, down there.
Is that because of the pump?
What's that?
Is that because of the fluid pump?
No, it's my finger. It's my tremor. Nobody's objecting. It's sad. Whatever. Here you go. So yellow ligament here, and then right behind the yellow ligament. And again, this is a tiny, tiny little kerison, right? But if you use it right, it does do some damage. So it works. Just have to use it very. I mean, and again, honestly, that's one thing that I always try to tell my residents: if you can use these little tiny instruments, then you're the king with the number 4 kerison, right? Or even
Christoph, Dr. Wagner says all famous surgeons have tremors.
Oh my God. Luckily, you know, you can't start anything on Twitter about me. I have only 5 followers, so don't worry. All right, so we do, and then you can go out with the drill and drill it down a little bit if you want to. The nice thing about this, again, I don't know how much time we have, Daniel, to continue here. Obviously, could continue here forever. Is there anything in particular that you guys would like to see, or how are we doing time-wise? Again, I just want to point out that we didn't take a single X-ray for getting all of this, this done, and it was pretty efficient. So yeah, just drilling out a little bit more of the SAP ventrally here with the drill. You can see make dust here a little bit, rolling up some of your ligament.
Did you register the drill before you used it? I wasn't sure if we're seeing the drill.
No, because now everything is anatomy, right? We have the pedicle. I don't need any. At this point, you don't need anything. It's all anatomy here. Here's the nerve root back there. Now you can see it much better. You see Vapoflex. Let me just point that out.
We started doing endoscopic T-lifts yet?
They're easy. It's just not as big of a graft, and so I do it for certain very limited indications. So the nerve root is right back in here. You see that? Right. This thing here. It's just very collapsed. So it's right underneath the yellow ligament, and then here's obviously epidural space, so you can go in there forever. So the nice thing about this approach is you can go all the way to the midline and even contralateral and around the epidural. So if you have young patients, if a couple of football players that we treated like this that have those central disc herniations, and young patients that don't smoke, they actually heal from that. So you can take a big central disc herniation out like this. So here now the nerve root is a little bit more clear. So right, this white stuff right up there to the left of is the dura coming down there. So you see that on the left side here. Mm-hmm. That's the dura. Okay.
So for a central disc herniation, you would go transforaminal rather than interlaminar?
Yeah, because then you don't have to move the whole the whole package to the side. So it's a great approach. I mean, I think it's just something that I would not like to miss in my armamentarium. And again, a third of my patients have like some type of transplant, organs that I've never heard about, kerosene. And the nice thing about not to have to worry about infections and other stuff is just a game changer. Anyhow, so I'm happy to kind of keep going here right now, but basically we did the approach, we saw the traversing nerve root. In order to do a foraminotomy, you'd have to remove the yellow ligament, and then back here underneath there you would find the exiting nerve root. You see this fat up there? Up here?
Yep.
Up there is underneath that yellow ligament. Give me the scissors. Here this is. So that's the difference between the the scissors, the micro punch. I get one of my specials.
How would you do a lateral recess decompression here?
Oh, that's a great question. So lateral recess decompression, the great thing about doing it transforaminally is you can decompress the nerve root both dorsally and ventrally. So, and I don't know if Ralph Wagner already gave, this is it, drill, where he gave his talk. So the Germans love to drill down the posterior superior marginal osteophyte there. So here's a pedicle, dorsal thing, and so you basically go right in front of the nerve root and drill down this marginal osteophyte. And you protect it by the PLL, so it looks crazy, but it's actually very safe. And you can drill down this marginal osteophyte right in front of the traversing nerve root, and then you can also go dorsal to the nerve root with an articulating drill or that, and also drill down the medial aspect of the SAP and resect the yellow ligament. And that's why we, in our AO nomenclature paper, where we basically just standardized we have 28 worldwide surgeons on there, where we said, well, how should we call this? And so that's why we called it not like a ventral facetectomy or like a medial facetectomy, because an endoscopic transforaminal decompression is really decompressing the nerve root both dorsally and ventrally. So it's very, very thorough. What it's not so thorough is the rostrocaudal extent. So that's better with the interlaminar technique. So as you can see here, I drilled down that ventral do you have the Vapoflex? So traversing as a lateral recess decompression is very thorough because it's ventral. So we drilled in here, again, ventral to the nerve root, which is in here, and then you can take out the dorsal compression too. And you can go all the way midline by taking this entire bone out if you want to. But again, you see what I accomplished with reaming, but you could go back here and basically take the drill and drill all this out if you're bored. And then here, if I would do a foraminotomy, I would just go in here and remove all that yellow ligament. It's not uncommon to have that yellow ligament bunched up in the foramen. And again, I have I do see patients, my own ones and from other surgeons, where you have done, as we've heard from one of the speakers before, is you do the, Dr. Kim's talk, you do this T-lift and you don't remove this stuff. And I think he made a really excellent point of how important it is to clean out that foramen, right? Because every construct settles a little bit. And so all this can be cleaned out. The nice thing about the endoscopic technique, you can keep all the instrumentation in there and do it afterwards if a patient is symptomatic. So for the foraminotomy, I would remove all this yellow ligament here right now. You go north till you see the exiting nerve root, which I think you're starting to see here already. And then you can go dorsal to the exiting nerve root too. Vapoflex. And so here's a little bit of fat shining through. But again, it adds like 20 minutes to the procedure for sure to do a thorough foraminal decompression. So here is the annulus there in front. This is rostral. This is dorsal here right now. Here, yellow ligament. And if I follow this yellow ligament north, then I'm going to be right dorsal to the exiting nerve root, which we're seeing more and more. There's a little bit of disc annulus here in the foramen. And then here's the nerve root right behind that fat. And so you have to take all this out. So a lot of work to do. And in here, as you can see, that more stuff. So for foraminotomy, all of this would have to go. All this stuff here goes to the nerve root. All right.
So Christoph, I've been told you have about 3 or 4 minutes.
Yeah.
But whether or not you take down the yellow ligament within the foramen, is that based on whether or not the patient has foraminal stenosis on an MRI?
Yeah, no, I think that's an awesome question, actually, really. I mean, when we go in here right now and we treat, let's say we do a 4-5 disc here, right? The disc would be right in front of me here right now, would be just right to grab here. But some patients have also foraminal stenosis, right? Where it's collapsed because they've lost, it's kind of a flat tire, right? You've lost the disc height, and then this nerve root, the exiting nerve root, is crushed too. So in a case like that, I do more of a foraminotomy and also take down the yellow ligament so you create some extra space. And I think that's also the reason if you do a 4-5 disc and the patient develops a foot drop afterwards, often it's because the disc collapses into your foraminal stenosis with that. So those patients are perfect patients to treat then afterwards with a transforaminal decompression in that case. So it gives you a lot of options, and I like options. As we've seen today before, I mean, big open cases are fun, navigated cases are fun. We don't have a robotic system yet. But I think it really is part of the armamentarium for sure.
So are you doing all these cases navigated now?
We're starting to. So I'm really excited because I don't like to wear lead, like I think nobody does. And so I think I'm looking forward to reducing our radiation exposure and not to have to wear lead anymore. So we have it. We're planning to do the next couple of weeks. We'll do our first case. Any other questions?
No, that was fantastic. Really, again, you're one of the world's experts when it comes to endoscopic spine surgery, and I see more and more interest amongst fellow colleagues. I'm sort of in that in between from open to MIS2 based to endoscopic. I'm starting to make that jump as well. But this was a great live demonstration, and really thank you again for blessing us with an opportunity to see how you do these. Thanks so much, Christoph.
Jeff, one more thing that I wanted to point out there before you here is one thing that is really fun. On the left lower aspect, you actually see where the endoscope is looking. Don't ask me how they did that, but it really follows around there. So when I showed when I showed you the nerve root there, you can either trust me, but nobody does it anymore. But you can actually see that, look up there. It's just looking up right up to the rostral vehicle and as a pedicle, and right where we're looking, we see the fat. So the nerve root is right inside behind that fat. You see the glistening fat at 3 o'clock? Mm-hmm. So it really matches perfectly well. So it's an amazing accuracy. So I think it's going to be really also very helpful for flattening the learning curve. There's so many curves you have to flatten these days. It's crazy. We used to like curves, but not anymore. All right, anyhow, we'll take that afterwards. Okay, sorry. Thank you.
Thanks, Christoph. Appreciate it.